a little bit what is possible with ultrasound on the emergency and the intensive care, because I work on both departments. So we're going to see a little bit about abdominal ultrasound, a little bit about pulmonary ultrasound, and some little bit about cardiac ultrasound, but very basic, what you can do with the basic stuff. For me, it was very fun to learn ultrasound. It helped me in decision making, and for me it became a new partner in medicine. It's about clinical ultrasound, it's about visual medicine, so you have to know a little bit about anatomy, pathophysiology of your patient, the semiotics, and clinical epidemiology. You can use ultrasound in the ABCDE assessment of every critical patient. You can look to all parts. You can do ultrasound, cranial, soft tissue, abdominal, vascular, even from the eyes. You can do ultrasound to see if there's intracranial hypertension. What's fun for me, it's for critical ill patients, about acute dyspnea and shock in critical departments at critical moments, and for a lot of pathology and decision making. So this is an image of the old computer software that we have for our ED. Very busy department sometimes, and then you have to make decisions. What patients go to the CT? What can you do yourself? So why ultrasound is done by the physician who takes care for the patient in critical scenarios. No time, no resources, to obtain very simple answers, yes or no, to simple questions arising during the clinical evaluation. And every anatomical site is almost possible. Simple and fast, shorter stay, less movements. You can do it pre-hospital, but the pre-hospital literature has a lot of bias. We think it works, but the literature for that is very difficult. In the ED and ICU, you can do fast plus rush exams, or why be so selective? Do whatever you want. What do I see regular or semi-regular? Pneumothorax, sternal fractures, acute pulmonary edema, CPR, rush protocols, pneumonias, pleural fluids with or without punctures, aortic dissection problems, all kinds of abdominal pathology, thyroid problems I can diagnose with ultrasound, basic cardiac evaluation, basic veins, and the fast in trauma and shock. So we're going to do a walk through ultrasounds and make you a little bit enthusiastic to learn it. For acute dyspnea, it can, I think, replace standard chest radiography for the acute evaluation of your patient. And you already heard Daniel talk about this blue protocol, and I think it's a very relevant article, the one you have to read. And there is the blue protocol. You start with lung sliding being present or abolished. Then you're going to look for the profiles A, B, or C. And then you can make a diagnosis. This is for acute dyspnea patients admitted on the intensive care. Those are very ill patients. Not every emergency patient fits in. And I'm going to give us a few examples what you can do with this. So a male patient comes in, no major pathology in his prior history, has no fever, has fatigue for some weeks, has some stomach pain and dyspnea since 2 days. And when you do the lung ultrasound before you have the chest x-ray, as a classical example of B lines or lung rockets, this is the pleural lining, and a lot of all the A lines are abolished, and this is a very typical image of B lines. When you have this bilaterally, you have acute pulmonary edema. This is a chest x-ray 10 minutes later. You already have the diagnosis of acute pulmonary edema. Of course, with this kind of acute dyspneic patient and acute heart failure, you need, of course, further ultrasound for the cardiologist. He had a mitral valve papillary muscle rupture, and he needed urgent surgery. Lung sliding being present, A profile with PLAPS, going to see an example, probably pneumonia. PLAPS is for posterolateral alveolar and/or pleural syndrome. It's scanning for pneumonia. In the emergency department, I let the patient sit up, if possible, so you can see the dorsal chest where most of the pneumonias are lying dorsally. In a sitting position, you look for the diaphragm, diaphragmatic space, and you can use both probes, depending on how fat your patient is. An example of fever, chest pain in an old man with coughing and pain on the right side at the base of the chest. This is a difficult chest x-ray. You can't really tell this is a pneumonia. And when you do the scanning with a linear probe, you have a very big image of what you're looking for. You see the rib shadow, diaphragm line, and you see some pleural fluid, and the lung underneath is very irregular with what we call C profile. This is a typical example of a lung with pneumonia. Other kind of image, same patient, pleural fluid, a very sick, very irregular lung, white, gray, dark, not very good lineated. It's typical for a C profile, and it's typical for a pneumonia. Pneumothorax. With pneumothorax, we don't have any lung slidings. We have A-lines with or without lung point. Female, she fell in the bathroom, severe rib pain, 6 to 10, no dyspnea. This is a chest x-ray. It's difficult. You can maybe expect there's a small pneumothorax. Here's a rib fracture. And when you do the right basal part of the lung, you have normal lung sliding. I had dropped my probe a few weeks before, and half of the probe was gone. My boss was not very satisfied. But this is normal lung sliding. When you look at another patient, that's not the same patient, you have rib shadow, and here there is absolutely no movement of the pleural line, whatever. And with a lot of A-lines, it's typical for pneumonia or pneumothorax when it fits in your diagnosis. Be careful with patients with severe COPD, emphysema, or who had already had what you call telcars of the lung. They can have abolished lung sliding. So not every patient with abolished lung sliding is going to be pneumothorax. It has to fit in your diagnosis. Here, okay, sorry. Here you see typical lung point. So this is the pleural line that's not moving, and sometimes this little window comes in with lung sliding. It's very typical of lung point. The lung comes to the probe and goes away. When you see this is pathognomonic for pneumothorax. There's no other imaging in medicine that gives this kind of image. So when you see this, you have a pneumothorax, but not completely. It's a small pneumothorax. And when you see on the CT scan, there's a small pneumothorax, but you can detect it very easily with ultrasound. After chest drainage, another patient, the lung sliding is back again. So you can also use the ultrasound. You don't need an X-ray anymore. When the chest drain is in and you have completely normalized pleural movement, you don't need an X-ray to confirm that the pneumothorax is gone. It helps you in making decisions. Obese man, truck driver, accidental retropulsor climbing in his truck. He made a fall of 2 meters. He had on his chest X-ray rib fractures. He had a contracoup bleeding intracranially, and on the CT scan of his chest, he had a small pneumothorax left-sided anterobasal. And he went in progressive stupor. So what you're going to do now, you have this small pneumothorax, you have to intubate your patient. Are you going to put the blinded chest drain left-sided because of small pneumothorax prior to intubation? That's always a difficult thing. The literature can say that you can wait with these patients, and knowing there's a pneumothorax, if the patient goes less good, blood pressure drops, and you can still put a chest drain in, but at what timing? So what happens, of course, 5 minutes after intubation, his blood pressure drops. Is this due to hypovolemia? Is it due to medication? Or does he have a tension pneumothorax? Just put on the ultrasound. I had a perfectly normal pleural movement on most part of the lungs. So you don't have a tension pneumothorax. It's due to the medication. So you do not have to rush putting a chest drain in. More difficult patient on the intensive care, Hodgkin lymphoma, major chemotherapy, progressive respiratory failure, interstitial and alveolar lung disease. She received a lung biopsy, diffuse alveolar damage with organizing pneumonia. And then with the chest drain in, she develops a pneumothorax with a chest drain in already. So it's a very sick lung, and the ventilation is not going very well, so you probably need another chest drain. But where are you going to put this? She's on ECMO, she's on hemodialysis, a lot of Christmas trees. This is a difficult patient. Where are you going to put this chest drain? And ultrasound can help you to decide. Normally, we put the chest drain in intercostal 2 or mid-axillary line. When you look with ultrasound on the intercostal 2 line, you see some movement of the pleura. When you put in a chest drain with this kind of sick lung, you're going to put a drain in the lung and make the patient worse. When you look mid-axillary, you see also some B lines, some little movement of the pleura. There is no pneumothorax over there. When you have B lines, you don't have a pneumothorax. So I looked at the other space, and here is complete still stand of the pleura. This was the ideal position to put the chest drain in. Anatomically a little bit different than you're used to, but this is the most safe approach. Something about pulmonary embolism. So A profile, and you have to look for thrombosed vein. Acute ill patient, dyspnea, shoulder pain left-sided, vomiting, and she was on methylprednisolone for a brain tumor. This is a chest X-ray. This is a chest X-ray we rarely see. There is no vascular imaging on this side. It's very rarely seen. You can make a diagnosis of acute pulmonary embolism on this chest X-ray. It's rare. You rarely see it. But then we are for ultrasound. Normal pleural lines, normal A lines. And when we compress, this is the vena, femoral vein. It can't be compressed. And there's a little thrombus in it. I think this is from another patient. You really see the thrombus in the vein. It's very simple. When you see it, you have a positive sign, you have a diagnosis. When you don't see a thrombosis, you cannot make a diagnosis definitely if there's no thrombosis, but with positive scans, you have a diagnosis. This is a normal compression again. And what I do then is the extended blue protocol. I also look to the heart, and it's not a perfect image, but I had a dilated right ventricle with some D shape. The left ventricle was rather flat, so it fits in with pulmonary embolism. So you can treat the patient without going to the CT scan. But of course, chest physicians still ask for CT scan. You do not need it for your diagnosis and your treatment. So for ER and intensive care, you're finished. You can have perfect treatment. Afterwards, we did a CT scan and major pulmonary embolisms. Another female, 3 days back from Bali, sudden cardiac arrest at home, CPR for 1 hour, a lot of adrenaline and thrombolysis, and she had ROSC and developed a new cardiac arrest on arrival on the emergency. So very high risk story for pulmonary embolism. And we did the ultrasound in the acute setting. This is the left ventricle, completely empty, completely flattened, and extremely dilated right ventricle. So you have, with this confirmation of acute pulmonary embolism, and with treatment, you see that the ventricle gets a little bit better, but she didn't make it. The blue protocol from Daniel Lichtenstein is only a guide. It's not more than a guide. So we had a patient with B profile, should have been pulmonary edema, but can also have PLAPS and pneumonia. It's difficult when you read the article. Bilateral predominant B lines. Most cases, on the 60 cases, are pulmonary edema. Some had COPD and some had pneumonia. But you can also have different things. So this is not that old lady who came in. Prior history of smoking, cocaine, heroin, methadone, a lot of viral things. She became dyspneic 2 to 3 weeks prior to presentation, pain with breathing right-sided. House doctors put her on antibiotics, did a chest x-ray in our hospital, so we could make some comparison, and the dyspnea got worse. Chest x-ray 2 weeks before, on presentation, right-sided is some consolidation, bad lab, lactic acidosis, bad blood gases, not that high CRP, and ECG signs could be fitted with pulmonary embolism. She was admitted on the intensive care, a lot of DD, empyema, right-sided endocarditis, DVT, pneumonia, so blindly put on antibiotics and heparin. Is this correct? You don't have a good diagnosis what's going on. Heparin is a dangerous therapy for me. And during the night, there was no further investigation. Lung ultrasound helps. It's fast. It's simple. Can give other answers and can give answers if you have to use heparin or not. So I did the ultrasound of the lung, and we see some B lines. It was bilaterally, so it can fit in with pulmonary edema or bilateral pneumonia. She had some PLAPS, but then when I look to the heart, I have this image. And you do not have to be a cardiologist to diagnose this kind of problem. So we put in a drain, bloody pericarditis, had a metastatic non-small cell carcinoma, and died a few weeks after. Shock. This is a typical problem in the intensive care and emergency. I already talked about this morning. It's about pump, tanks, and pipes. I advise you to read the Rush article. It's a very good, extensive article, but if you read it, it makes much sense how to use the ultrasound afterwards. This is an example of the IVC measurement, 2 centimeters from the right heart. An example of using echo and shock. Women in the 70s, high blood pressure, smoking. She came in with acute severe chest pain, deeply shocked pre-hospital, and intermittent spastic movements of the left arm. So you have this acute chest pain with low blood pressure and neurological signs. It's pathognomonic for aortic dissection. And what she comes in with this. And something, it's difficult, sometimes it works. I put the ultrasound probe here, and what we see is the aorta with a nice flap, typical of a dissecting thoracic aorta, and I could convince the cardiac surgery without CT to operate the patient, and she survived. Whole body ultrasound for you can use it in ICU post-CABG surgery. I was on call in the evening, sudden drop of the blood pressure, and the chest tube remains dry. Then you have a problem, because what's going on? What's causing the shock? And then you put the ultrasound on the lung, you see a lot of pleural fluid, a lot of fibrinogen in the pleural fluid. You know there's blood in the pleural space. The chest drains are not working, but you need a surgeon. One other patient, post-operative Staph aureus endocarditis with multi-organ failure. On day 10, sudden respiratory failure. It was very difficult to ventilate, sudden high CO2 and very high lactate. and you don't know what's going on. So you take the ultrasound machine and you start scanning what's going on. And to my big surprise, I had some pleural fluid. This is a diaphragm. This is the liver. And I have a lot of white dots in the liver. This is very rare. And you know that white dots is air. Air is not supposed to be in the liver. And, well, I did a CT scan, of course, because I can only see with the ultrasound there's a very critical problem going on. I had a lot of air in the liver coming from the vena porta, and this was a problem that you see air in the portal veins with a very sick abdominal intestinal system, and it's extreme ischemia, and this patient, of course, died. But then you have a diagnosis. Okay. Another one for the emergency, a patient fall from height, severely bleeding, head trauma, low blood pressure, a lot of blood on the stretcher. This is the fluid going in. But then, when you look on the ultrasound, completely empty heart. Left ventricle is empty, right ventricle is empty. I do not need these fluids. They are not transporting oxygen. They are not making coagulation. If you have this kind of empty-hearted problems in shock and bleeding, you give blood and not all the other fluids. Some basic and right-sided hypochondriac pain, gallbladder with stones, that's easy. Yeah? It's not that difficult. Having patient extremely high LDH, you know there's something wrong in the liver. Put a CT scan on, and you have this dirty image of the liver with a lot of big white dots. That's metastatic liver disease. It's not good for the patient, but at least you have a diagnosis. Another patient came in with globus post-cabbage 2 weeks after, but also had severe abdominal distension. Is there a globus? Yes, there is a globus, a big bladder, but there's also a lot of ascites. Had a non-diagnosed cirrhotic liver. Of course, it was present before cabbage, but he missed it. Sternal fracture. It's sometimes very difficult to see on the X-ray. And when you put the linear probe on your sternum, you can see, you look at the periost, it's always black underneath the periost, there's shadow, but you see that the periost is moving. There's the fracture. So with ultrasound, you can diagnose a sternal fracture. Young lady, suicide attempt, jumped from second floor, no head trauma, spine trauma. Day 2 after trauma, you have this kind of problems. Two white lungs, of course, severely respiratory distress. There's no tube in already. And when you do ultrasound, you see some pleural fluid, but you see atelectasis. All the white things is air inside of a collapsed lung. And when I turned my probe, you very nicely see here the white things moving. That's air going in and out of an occluded, collapsed lung. This means there's atelectasis, but the air is moving. You still can get this lung open. So you do not need, I think, to intubate. We put her on BiPAP ventilation, and the lungs clear, very much came clear, and the patient did not need intubation. Of course, you can decide it without ultrasound, but with the ultrasound, you could very nicely see the pathophysiology, what was going on. Another problem of respiratory failure, and the question, do we need to puncture the pleural fluid, or is there pneumonia? A very sick lung. It doesn't get any better. It even gets worse and worse. And then the question is there pleural fluid? And of course there's some pleural fluid. There are some atelectasis, the typical comma sign. But this is already the lung with a lot of B lines. But there's not a lot of pleural fluid. So stay out of it. It's too dangerous to puncture this kind of patient. So there is some pleural fluid, but not enough for a safe puncture. Okay, this is what last year's some examples of what I do with ultrasound in the emergency and on the intensive care. So I hope I can make you a little bit enthusiastic to learn this. You have a lot of courses. Of course, we had a hands-on now and IFAD. You can go to France. Daniel gives his own lectures also in English in Paris. Maybe it's not safe in Paris for the moment. I did the WIN focus. It's not always in Europe. It travels around the world. It's a very broad echo course in very sick patients. So if you have any questions, please.
What do you make the difference between atelectasis and pneumonia?
Well, with the atelectasis and you have air bronchogram, it can be both. The atelectasis does not have this C profile. If you have the C profile, meaning black, gray, white, not very good lineated, then you have a pneumonia. All the other things that are smoothly is atelectasis. And of course you can have both sometimes. That's more difficult.